السلام عليكم، معكم الأرتي سارة. اليوم راح أتكلم عن موضوع الكابنوغرافي أو الكابنومتري. I will cover the definition, indication and contraindication, the uses of capnography, normal and abnormal waveforms, and also I'm going to mention some of the studies to support my points. Now the history of capnography. It was first established in 1930s. Then in 1950 it became a key component in the advancement of patient safety within the American Society of Anesthesiologists. They introduced the end-tidal CO2 use as a standard of care for general anesthesia and moderate to deep sedation for assisting the ventilation. So mainly the use of capnography in the past was restricted only for general anesthesia and deep to moderate sedation for assisting the ventilation status of the patient. Then the use of capnography spread and it became an essential tool in the intensive care units and emergency departments. Also, it will provide the clinician with a quick, reliable diagnosis of a common pulmonary pathologies. So what does capnography exactly means, or capnometry? Basically, both of them are synonym, but with a slight difference. Both of them are devices or tools for measuring or analyzing the exhaled CO2. But in more detail, capnography, it's the monitoring of concentration of carbon dioxide in the respiratory gases presented as a graph of expiratory CO2 measured in millimercury, plotted against time usually, or it could be plotted against volume, which is less commonly used in clinical field. On the other hand, we have capnometry, and it suggests only the measurement in numerical values without a continuous written record or waveform. يعني الكابنوغرافي راح يكون زي ما قلنا، يعني الكابنوغرافي راح يكون عبارة عن waveform مع numerical value، والكابنوmetry only numerical values without any waveform. Colorimetric end-tidal CO2. I'm sure everyone knows the indication for this type of end-tidal CO2 measurements for the verification of ATT placement post-intubation. But when we compare this colorimetric end-tidal CO2 to waveform capnography, we will find a drawbacks. It's not a continuous and it doesn't have any waveform or numbers or alarms, and it can be easily contaminated and it can give me a false reading. So we conclude that the use of waveform capnography has the superiority on colorimetric end-tidal CO2. Now regarding the capnography versus pulse oximetry, we know that the pulse oximetry for oxygenation wise, now we have a tool for the ventilation wise, which is capnography. When we compare both of them, the capnography will provide the clinician with an immediate picture of the patient's condition, in more detail, ventilation status of the patient. So for example, I have a patient and he's attached to both capnography and pulse oximetry at the same time, and the patient become an apneic. So the capnography will detect this fatal condition immediately, while the pulse oximetry could show me that the patient is saturating well for the first 30 seconds up to 1 minute, then the saturation start to drop. مثال ثاني للتوضيح، أنا الآن عندي patient and I'm ventilating my patient, but I don't know if he's perfusing well or not. The end-tidal CO2 level can tell me whether the patient is being perfused or not, because if the cells are releasing CO2, that means they are being perfused. That means the perfusion is fine and the blood flow reaching to the lungs is fine, and the end-tidal CO2 level in the normal range. Now I will talk about the indication of capnography. First, during cardiac arrest for assisting the efficiency of chest compression and to detect the return of spontaneous circulation immediately. أنا الآن عندي patient and I'm providing chest compression for this patient. End-tidal CO2 will work as a guidance to show me if I'm providing this compression efficiently or not by maintaining the end-tidal CO2 level 10 millimercury and above. And regarding the return of spontaneous circulation, it will detect it immediately by showing a high peak in the waveform. Also, there is a lot of studies showing that the survival rates for patients receiving chest compression with end-tidal CO2 level 20 millimercury and above greater than those receiving chest compression with end-tidal CO2 level 10 millimercury. The second indication is the verification of proper ETT placement. Regardless what type of capnography are we using, colorimetric end-tidal CO2 or a waveform capnography. Also for procedural sedation, for continuous monitoring of the respiratory pattern. As I mentioned previously, the use of capnography in the past was restricted only for the use of anesthesiologists to assess the patient's ventilation status during sedation, and also to give a quick spontaneous window of the patient's ventilation status, especially for critical and head-injured patient. It will help in preventing the slow management, thus improving the quality of care given to those patients. And as an RT, we know how important CO2 for head-injured patients. And as an RT, the only way we obtain CO2 level for those patients is by taking a frequent blood gas to maintain the CO2 in a normal range, preventing hyperventilation or hypoventilating. So if you are using capnography, it will minimize the frequent ABG puncturing. And the last point is the recognition of certain pathological conditions such as bronchospasm. Some of pulmonary pathologies will have a special pattern which can be easily recognized once we know the normal waveform of capnography. Regarding this slide, one of you asked yesterday about what is the difference between exhaled CO2 and arterial CO2. So I'm going to explain this now. Usually the difference between arterial and exhaled CO2 is less than 6, and the end-tidal CO2 is usually less than the arterial CO2. We have a normal range of the arterial CO2 from 35 up to 45. Regarding the contraindication, there are no absolute contraindication for using capnography. نفس concept استخدام البulse oximetry، ما في أي contraindication تمنع استخدام pulse oximetry مع أي نوع من أنواع البيشنت. Here I have a study about the effectiveness of out-of-hospital use of continuous end-tidal CO2 monitoring on the rate of unrecognized misplaced intubation within a regional emergency medical service system. So in simple words, هذه الدراسة تتكلم عن two groups. One of them use end-tidal CO2 during intubation and the other doesn't, and they will see the percentage of unrecognized misplaced intubation with those groups. So the conclusion was no unrecognized misplaced intubation were found in patients for whom paramedic use a continuous end-tidal CO2 monitoring, and the failure to use end-tidal CO2 monitoring was associated with 23 unrecognized misplaced intubation rate. The normal waveform. قبل لا أبدأ أشرح إيش هي phases of the normal waveform, I'm going to emphasize on some of the points. That the respiratory rate usually between 12 to 20 breaths per minute, and the breathing pattern occurs approximately once every 3 to 5 seconds. يعني راح أشوف هذا الويف فورم كل 3 إلى 5 ثواني في المونيتور screen. And the inspired air obviously doesn't contain any CO2, and the expired air contain about 4 to 6% of CO2. الآن راح أبدأ أتكلم عن ال phases of a normal waveform. عادة هي 3 phases، وبعض المصادر تقول إنها 4, but it's the same concept. Anyway, so we will start with phase 1, which is baseline. It's reflecting the inspiratory baseline, which is normally start from 0, because we know that, as we mentioned earlier, the inspired air doesn't contain any amount of CO2. Then we will move to the second phase, which is phase 2. We call it the expiratory upstroke. When the beginning of inspiration, it's the beginning of expiration, sorry. and it is the transition of anatomical dead space that doesn't participate in the gas exchange. يعني هو عبارة عن الأير اللي يكون في ال upper airway like trachea and so on, وهو يحتوي على a little amount of CO2. Then we will reach to the and as I said, the most important phase is phase 3, which is the alveolar plateau, reflecting the highest point of CO2 level, where the end tidal CO2 reading will be shown. Then after a full exhalation is being done, phase 1 will start again, and the cycle will repeat itself in each breath. هذه الصورة عبارة عن a real monitor screen with a capnography attached to the patient. هذا آخر شيء، هو عبارة عن ال end tidal CO2 level for this patient, and as we said, for a reminder, the normal range from 33 up to 40. بما أنه تو شرحنا ال normal waveform, obviously we will move to the abnormal waveforms, and for me I categorize it into 3 categories to make it easy to memorize it يعني. So category 1, when we have high CO2 level, hypercapnia, and category 2, when we have a low CO2 level, hypocapnia, and last category when we don't have any CO2 level, apnea. And also there is a few waveform patterns that doesn't fit into these categories, but I'm gonna explain in a second. They are very simple. So in this capnogram, we could see a gradual increase in the end tidal CO2 level. So basically there is a buildup of CO2 as a result of insufficient elimination of carbon dioxide or CO2, regardless what is the cause. And here we could see a normal monitoring screen with high end tidal CO2 level. We could see how huge and large this waveform here. And there is a lot of causes that result in high end tidal CO2 level, but I mentioned a few of them only. So 1, with malignant hyperthermia, it is a life-threatening condition where the patient body temperature increase. And so as I said, malignant hyperthermia is a life-threatening condition where the body temperature increase and gets into the cycle of hypermetabolism, and we know that the end byproduct of this metabolism is CO2, so it will result in increase in CO2 production, and the body will get into both metabolic and respiratory acidosis. So an early clinical sign of the presence of malignant hyperthermia is having high end tidal CO2 despite high minute ventilation. إيش يعني؟ يعني إنه البيشنت having a high minute ventilation and still he's not washing out CO2. It could be a sign that the patient having malignant hyperthermia. Second cause is sepsis. Third is central nervous system dysfunction, either if it was infection like meningitis or a congenital. Fourth is narcotic overdose. We know that narcotic overdose will cause respiratory depression resulting in hypoventilation and accumulation of CO2. Fifth cause is hyperventilation syndrome, the same concept. And last one is obesity hyperventilation syndrome. In this capnogram, we will see at the first it's a slow and has a normal end tidal CO2 reading, but as the rate gets faster, the waveform gets narrower, and there is a steady decrease in the end tidal CO2 below 30 millimercury, and it's resulting from either excessive breathing or a deep breathing. Causes of low end tidal CO2 level. For example, we have anxiety or panic disorders. Usually patients with anxiety or panic attack will tend to have a high respiratory rate, resulting in washing out their own CO2 and getting their pH to the alkalotic side. So one of the solutions is to give them a paper bag and let them to rebreathe their exhaled CO2 from this paper bag. The second cause is hypothermia. It's the opposite of hyperthermia, as I already explained previously. Third cause is low cardiac output. Once we have a low blood perfusion to the lung, it will result in a low exhaled CO2. Fourth cause is pulmonary embolism. With pulmonary embolism, in emergency department or outpatient settings, capnography can be very helpful for a quick, reliable, it's not diagnosing, but in suggestive diagnosis of the presence of pulmonary embolism. So a low end-tidal CO2 value, it may indicate that the pulmonary embolism is present, and a normal end-tidal CO2 or high end-tidal CO2 level should suggest that the pulmonary embolism is very unlikely to happen or be present, since that there is no increase in the dead space ventilation. So I'm not saying it's like the gold standard in diagnosing pulmonary embolism. It's only a tool, a helpful tool in suggestive diagnosis in emergency department for the presence of pulmonary embolism or not. So the fifth cause of low end-tidal CO2 is hyperventilation, especially with metabolic acidosis patients. And the last cause is overzealous bagging. Sometimes excessive bagging and aggressive bagging could result in washing out the CO2. هذا الكابنوجرام أو الويف فورم pattern أعتقد جدا واضح. هنا عندي normal waveform, بعدين a total loss of those waveform transforming into a flat line. In this condition, that it's mean that there is no CO2 is being exhaled. So the capnography will allow immediate recognition of this fatal condition. We have multiple causes of apnea, for example, cardiac arrest or respiratory arrest. Sometimes it could be an equipment failure, either blocked ETT or something wrong with the capnography itself, and obstructive sleep apnea patients. هذا الكابنوجرام أو الويف فورم أول ما نشوفه راح نقول إنه normal، بس لما نركز شوي راح ننتبه إنه ال phase 1 doesn't return to the baseline. This waveform is called rebreathing of CO2, and it has multiple causes. One, when we have an air trapping in patients with history of asthma or COPD. Two, malfunction in the exhalation valve of the bag valve mask or the ventilator itself. Three, rebreathing of exhaled gas, tent effect. And the last one is insufficient expiratory time. Now, regarding the rebreathing of exhaled gas, the tent effect, usually we know that when we put a patient on a simple face mask, we put a minimum flow rate of 6. Why? So why 6 is the minimum flow rate with patients need a simple face mask? To avoid the CO2 accumulation and making the patient rebreathe again their exhaled CO2. It could be a solution, as I said previously, with a panic attack or anxious patient, because they are hyperventilate and they are washing up their CO2. And this waveform, it's during the chest compression and return of spontaneous circulation during CPR. So the end-tidal CO2 can be the first sign of return of spontaneous circulation, and during cardiac arrest, if we see that the CO2 number shoots up, and as I said previously, as a high peak, we should stop chest compression and check for the pulse. So in this case, capnography will improve the quality of care given to patients during CPR by letting the paramedics or the healthcare providers performing a continuous and efficient chest compression without disruption to checking the pulse every once in a while. Once we see this high peak in the waveform, we will stop and check the pulse. So I know it's like a lot of waveforms, but once we get and understand the normal waveform and its phases, we could easily recognize any abnormal waveform or pattern. So here we could see like a normal waveform with the 3 complete phases, which is inspiratory baseline, then the expiratory upstroke, then the third phase, which is the alveolar plateau. In this second waveform, we could see a clear loss of this alveolar plateau. This patterns occurs only with bronchoconstriction cases, like for example, patients with asthma or patients with COPD, or it could happen with a partial airway obstruction, or kinked ETT, or obstructed by mucus. Our last waveform pattern is called acute clefts, where there is a clear depression in the alveolar plateau. And this waveform, it could happen only in two cases, either in a mechanical ventilated patient when he tried to be awake from sedation and try to inspire against the ventilator. In this case, we should give the patient sedation unless we want him to be awake. The second condition or case when this Curie cleft pattern happen, when surgeons manipulate the chest or at the abdomen of the patient during surgery. Now our last point to cover in this presentation is capnography with head injured patients. I know head injured is a long subject, but we know how important CO2 level for those patients. So using capnography with them is like a gold standard in management for them. We are preventing hyperventilation or hypoventilation by providing a continuous monitor of CO2 level without the requirement of a frequent ABG puncturing. So we know that the CO2 is like a cerebral vasodilator. So once the patient being hyperventilated, it will decrease the CO2 level and result in decrease the intracranial pressure. And this decrease in the intracranial pressure will decrease the blood flow, and the patient will have cerebral ischemia. هذه الصورة أوضح للإفكت of CO2 with cerebral blood flow. So in the second case, when we have hypoventilation, where the CO2 level increase and it will have the vasodilation effect, then increase the cerebral blood flow, increasing the intracranial pressure, and the patient will have cerebral hemorrhage. So we don't want to cause either hemorrhage or ischemia to the patient. Now we reach our last slide in the presentation, and we conclude how important the use of capnography in intensive care unit and emergency departments, and it's not restricted only for sedated patients. I hope you understand it and you enjoyed this presentation. Thank you for listening.